Recorded. I think Shreya has done it. The meeting is now being recorded.
आ गया भाई, आ गया।
और welcome,
भास्कर तू
welcome. So,
जंगल में
हाँ,
वेलकम भास्कर। तूफान सर समुंदर में, तुम जंगल में। चलो, ऑल द बेस्ट।
चलो start करते हैं. Share the slides, please. Can we have the slides now? Introduction. Yes, thank you. Thank you and welcome all of you to this 206th edition. Today we'll try to mix and match what is wrong, what is right, rational versus irrational, polypharmacy in our field. So everyone will be on the mute mode. The panelists can unmute themselves. Questions are invited in the chat box. And yeah, the session will be recorded for YouTube viewing later on. So let me, next slide please. Please allow me to hand over the session to Professor Dr. Tufan Kati sir, who is the chairman of this program. Tufan sir, over to you.
Thank you, Dr. Ali. Good evening, everybody. I shall be briefly introducing Dr. Alim Siddiqui, Dr. Amrit Bhattajoshi, and Dr. Slides, please. Amrit Bhattajoshi and Dr. Vishal Chabra are the vibrant moderators of this program. And welcome all the moderators. I have the pleasure to introduce Dr. Rajesh Jain from UK as a chairperson in this session. He is MBBS from SMS Medical College, Jaipur, and MD from CIP Ranchi, and working as a locum consultant psychiatrist in different organizations in different subspecialties of psychiatry in UK for the last 19 years. Welcome, Dr. Jain. Next slide, please. Dr. Binay Lakra is President of the Royal Australian and New Zealand College of Psychiatrists, Divisional Director of Mental Health Services of Northern Health in Melbourne, member of Victorian Board of Medical Board Australia, MBBS from Jain Medical College, India in 1999, MD from CIP India 2002, Fellow of Royal Australian College of Medical Administrators, Masters in Health Management from University of New South Wales and is a graduate of Australian Institute of Company Directors. Is Clinical Director of Mental Health Services at Northwest Mental Health, Deputy Chief Psychiatrist of Victoria for 3 years during 2016 to 19. Member of WP Standing Committee on Scientific Sessions. Welcome, Dr. Lakra. May I request Dr. Zain to kindly introduce our speaker, who is Dr. Bhaskar Mukherjee, whose slide is being presented. Dr. Zain, kindly do the favor. Hello.
This is the most difficult task to introduce Bhaskar because words are not enough to describe his abilities and his talent. And he is a very unique talent in the world of psychiatry, that who basically not only understands the fundamentals of medicine, assimilates, synthesizes, and analyzes, and also translate into the clinical practice, which is very, very rare. Because I've come across a lot of professors in my life who are good researcher or who are good trainers or teachers, but somehow it does not translate into their clinical practice. I worked in Maudsley, and I've seen the opinion what I said just now. So on the top of that, in medicine, one of the difficult tasks for the clinician to understand the genetics, and then also neurology is also tough, and he has attained the mastery in both these things, and still remains a very fine clinician. So we are very fortunate and we are very blessed that he continues to share his wisdom and knowledge in WhatsApp groups and in various webinars. So we are highly grateful to him, and I am now I would like Dr. Lakra to speak a few words about the topic.
Thank you, sir. So, I think I want to just make some correction. I am not the president of the Australian and New Zealand College of Psychiatrists currently. I finished my term last year. I think this is probably one of my older slides when I chaired a session. And I'm also not on the medical board in Australia. I finished my term there as well. But anyway, it's a pleasure to be here with everyone. And thank you, Rajesh, for
corrected you had been. Let us understand like that.
Yes, sir. Yes, sir. So, because it is recorded, so it's important to correct it when
Okay.
people watch it. So, the topic today is polypharmacy in psychiatry, rational or irrational. As all of us can understand, when we see patients, that there are a lot of patients who are on more than one medication. Sometimes it is because more than one medication is needed. Sometimes it's because the primary medication is causing side effects and something else gets added. Sometimes medications are added for different symptom domains. For mood problems, something gets added. For psychotic symptoms, something gets added. For agitation, irritability, something gets added. And there are times when it's clinically needed, and there are also times when patients and their family members they identify specific areas. And so it's not uncommon for us to see people on polypharmacy. And one of the things which we are very regularly taught is how to start a medication. But I don't think there's not enough emphasis on how to stop or withdraw medications which are not useful for the patient. So, in that context, sometimes rational polypharmacy can become irrational polypharmacy. And so, the boundary between rationality and irrationality can be very fine sometimes. And so, hopefully, Bhaskar will enlighten us today about polypharmacy and what its benefits are, and how we can be more rational in choosing polypharmacy. Because I think one of the, besides, of course, the burden of side effects from different medications, one of the other factors for patients is the cost of medications. So when there is more than one medication, everything gets added up for patients. And so I think there are several reasons why we need to rationalize polypharmacy if that is what is required. And so let's hear from Bhaskar, and Bhaskar will enlighten us, and then we'll have some question and answer towards the end of it. Thank you. And once again, thank you to the team for giving us the opportunity.
Okay. Thank you for the introduction. That was too much of an introduction. I would say I don't definitely feel that I am not worth of that much praise. But anyway, nobody really listens to my observations. But so let me just keep to the today's topic and how today's topic makes a very interesting turn in the treatment process that we have been taught. Because I remember when I joined my MD curriculum in end of 2003, people used to teach never do polypharmacy. Polypharmacy is something that is to be avoided at all cost. And now, after exactly 21 years, I am in a forum teaching about why not to do monopharmacy and how and where judicious polypharmacy is needed. Really a full circle. So with that, let's talk about polypharmacy in psychiatry and what we meant by rational versus irrational polypharmacy. This would be actually the talk flow. But remember, depending on time constraint, I might have to skip some of them or might have to elaborate more on some of them. But this is the general idea of today's talk. We have to first analyze why the monopharmacy is not going to work in any patient. Number two, we have to understand that if we are going to do polypharmacy, what would be the way forward? Then we would start exploring symptoms rather than imaginary conditions like schizophrenia, bipolar, which doesn't exist really. Then, what is meant by sequential treatment? I have tried to make it in a single format. Then, step up treatment versus step down treatment and demands of the real world. And I would try to sum up all this in final slides. Today, it would be a very simple slides, not the way I make slides, because the topic is not simple. So, when we start talking about polypharmacy, we first should talk about what are the faults of current monotherapy system. Current monotherapy system in psychiatry is rooted on neurotransmitter theory, which is completely outdated. And this current obsession with monotherapy in psychiatry has no real world reflection in any other non-communicable disease segment, because all we treat are symptoms of genetic diseases of brain. So standing there, it is impossible to not to draw corollary between our non-communicable disease segment and other non-communicable disease segment. And in no non-communicable disease segment in body, there is monotherapy. They don't even understand that. So first we will discuss about the limitation of neurotransmitter theories, because that is what directed this monotherapy or monopharmacy approach of ours. Brain is a very complex system. Brain function involves networks of billions of neurons and trillions of synapses, and together they form a bioelectrical grid which is dynamic and which is functional. Then there is underlying molecular, genetic, and various omic system grid, which again is very, very vast and complex. Standing there, just focusing on some of the cell-to-cell transmission is just like talking about one star in a galaxy of stars. This would be so undermining to the whole complexity. And standing there, even neurotransmitters are more than few thousand in number. And all psychiatry talks about is serotonin, dopamine, noradrenaline, glutamate, and GABA. And since last 10 years, endo-opioid and endocannabinoid. Talk about oversimplification of the oversimplification, that would come into psychiatry understanding of brain. And so psychiatric disorders, we don't have any disorder. Again, I am saying these are just symptoms, and they arise from dysregulation of multiple neuronal circuits, pathways, not just some simple neurotransmitter imbalances. And in neurotransmitter theory, there is no proof of any of the brain processes involving any specific neurotransmitter. There is no proof that executive function is controlled by such and such neurotransmitter. There is no proof that motivational circuit is controlled by such and such neurotransmitter. There is no direct way to measure a specific neurotransmitter change exclusively associated with a specific drug. If I say I am giving sertraline and I am seeing a rise of serotonin in brain, then I am bluffing and I am directly telling a lie because there is no way to measure that. It is just our inept 1960s hypothesis, which we are still dragging on. And beyond our holy monoia minds, as I have already talked about, there are thousands of other neurotransmitters, and these neurotransmitters or cell-to-cell transmitters are as much important in our drugs action as is the monoamines. All our drugs work on neuropeptides, all our drugs work on NOS, all our drugs work on various redox pathways, and so on. So standing there, it is impossible. And this lack of direct evidence limits the strength of causal claims between neurotransmitter levels and psychiatric condition. Dopamine doesn't do anything in psychosis. Serotonin doesn't do anything in depression or OCD or things like that. And so this neurotransmitter based action, if isn't there, then how can we even say that we are giving this drug for this effect and that is why I am not going to give any more drug? This sounds utterly foolish. And lastly, if antidepressants were acting on serotonin and depression is due to lack of serotonin, then given serotonin in any form help? It doesn't. And also antipsychotics, which are theoretically serotonin and dopamine antagonists, would have uniformly pro-depressant action. It doesn't. Many of the people who see regular patients, they know that many a time they encounter patients who are stable on olanzapine, but whose symptoms are of so-called depression, and stopping the olanzapine would cause the depression to relapse. Similarly, many of the patients are in a combination which none of which are known by any extent to be antipsychotic, but stopping those medication causes psychosis to relapse. So there is no way that these neurotransmitter hypotheses are really very scientific. And if we go clinically, then all psychiatric symptoms and their treatment follow the same pattern. There is no neurotransmitter based classification in any treatment. It is just our, I would say, hubris or our fixed firm belief, if people want to term it that. And in this whole neurotransmitter idea or chemical locha, we have lost and we have neglected the understanding of brain functions, understanding of brain's molecular biology and genetics, understanding of brain development, neuroimmunoendocrinology, neurophysiology, neuropathology. And ultimately, it made our understanding poor. If we now I was talking about corollary between other non-communicable disease and brain's non-communicable diseases that we treat. I am giving two extreme examples. One is diabetes. This is a 2024 article of Diabetes, which talks about multimodal pharmacotherapy is the only treatment that should be given, and they are comparing it with insulin and sulfonylureas. Means they are combining multimodal pharmacotherapy, and they are comparing it with already ongoing polypharmacy. So they are not even bothered about any form of monopharmacy because they are directly saying that monotherapy with any single drug would cause rapid degeneration of other body system and would cause rapid progression of diabetes. And this is the current stand in diabetes, hypertension, dyslipidemia, metabolic syndrome as a whole, along with cancer and other things. There is no way an oncologist should say he or she is going to give up patient of malignancy a single drug chemotherapy. Then the other extreme is fracture malunion. Fracture malunion used to be at least fully known. These are the causes that causes fracture malunion, and there is just one way. Fracture malunion now even there they are saying polytherapy is much superior than monotherapy in case of any non-union, and this is again a 2024 paper. They are saying only bone graft is not enough. They are going to give biologicals, they are going to give various other scaffolding along with bone grafting, and that is better than just bone grafting. See the irony. The carpenters amongst medical specialties, even they are talking about polypharmacy and they are talking about multimodal treatment. So monopharmacy is illogical and scientifically incorrect. There is no place of monopharmacy in any treatment. But that brings us to the other end of it. The bombardment of illogical, irrational, improbable, and frankly disgusting polypharmacy that is going on around us. 3 antidepressant, 2 anti-epileptic, 3 antipsychotic, and 2 sedative combination. When I was a student, I have seen this type of prescription. Still, I am seeing this type of prescription. But this type of low dose shotgun combination is neither polypharmacy nor is it scientific nor is it logical. This is just a massacre of patients and nothing more. So polypharmacy is scientifically correct. Polypharmacy is logical, but that has to be polypharmacy which is scientific, sequential, and can be scientifically understood in a logical manner. So what makes polypharmacy rational? And this starts from assessment of the patient. First, we have to understand the pathophysiology. What specific type of brain defect we are dealing with? The longitudinal course, the family history of brain disorder burden, the family history of other non-communicable disorder burden, the present episode type, the risk assessment for acute destabilization, and other associated medical issues. Each of them have a role in determining which treatment we are going to give, and none of them really involve what specific symptom we are seeing. This is the background real pathophysiology that is there in the patient, and this first thing is consideration of how much that has affected the brain, how much that can be traced in family, and how much that can change the treatment process in the beginning. Then comes symptom type consideration, whether the symptom is coming due to hyperexcitability brain or not, whether the brain is working less or working more but intellectually to produce the presenting symptom. Here we are talking about presenting symptom. Then cognitive and emotional profile, and definitely this should not be profiled by psychometric assessment because that is something else. Then associated autonomic features, whether there is increased respiratory rate or panic attack or palpitation or GI disturbance or disturbance in genitourinary system in form of frequent micturition and urinary incontinence and other thing, or whether there is associated immune system dysfunction in the form of repetitive allergies, various form of dermatitis, various forms of other autoimmune diseases, and whether there is associated sleep, appetite, and other body dysfunction disturbances. All these has a say in deciding immediate treatment approach. Then comes the treatment proper. The basis of rational polypharmacy is layered treatment. First, to start with, one drug directed to most disturbing symptom, then one drug targeted to autonomic nervous system, one drug aimed at long-term prognosis, and one drug for rapid emergency relief, because our symptom directed and supportive medicine takes long time to work. So this is the layered treatment approach for any rational psychopharmacology. And now I would explain it symptom by symptom. Again, remember this fourth type. One drug for most disturbing symptom, one drug for autonomic nervous system, one drug for long-term prognosis, one drug for rapid emergency relief. This is the general schema. Now, let me elaborate this into practical area. And I would go from one symptom to other symptom. Low mood and apathy. Let's be very clear, depression, the disease doesn't exist. This is just symptom. And the most pathognomonic symptom is low mood and apathy. Yes, most people would argue that this doesn't come alone. There is anxiety. And yes, I have also touched upon anxiety, but first I am starting with low mood and apathy. So what causes low mood and apathy? The immediate pathology is brain failing to work adequately for months. And that failure is leading to constant low mood and constant apathy, constant low motivation, constant loss of energy, and other things. So this is the immediate pathology. But the immediate pathology is produced by the background pathology, and the background pathology is as varied as it is possible, because we have roughly 20,000 proper genes and few hundred open reading frames which can produce protein, and all of them can be involved in formation of this brain failing to work adequately for months. And that gives us roughly few billion disease possibilities. So amongst the few billion, which is happening in a patient is not possible to understand in first few treatment months. So standing there in first few treatment months, the main treatment should be directed towards immediate symptom producing pathology. And this is as true for depression as it is true for hallucination, as is it true for delusion and other things. And for understanding the background disease process which is leading to this immediate pathology, the best idea is to look at the patient from a life cycle perspective, from a family genetics perspective, from a total genetic vulnerability perspective. So our formula would be immediate relief measures combined with long-term measures, combined with autonomic nervous system modulation, combined with as and when you use SOS medication. Here, in case of low mood and apathy, that translates into euphorians or proper neuromodulation as immediate relief measures. Euphorians means ketamine, euphorians means magic mushroom, euphorians means ecstasy, euphorians means LSD. Whatever produce instant euphoria is euphoria. And proper neuromodulation means, let's say, RTMS, deep TMS, or TDCS. This would be immediate relief measures. They would give immediate euphoria. And obviously, we shouldn't forget ECT, because ECT is the strongest neuromodulation available to us till date. Then, for long-term measures, antidepressant. Antidepressant would give the brain more functional reserve, would give the brain more neuronal connection, more neurons, more neuronal stem cell, and ultimately more adaptability. Autonomic nervous system blocker for initial autonomic modulation, and benzodiazepine for SOS relief. Initial autonomic modulation can be done both by blockers and stimulants, because it is not always blocking is needed. Sometimes stimulation is also needed, but that would be dependent on understanding of the lifetime cycle. For example, in case of, let's say, a patient not able to work properly, not able to come out of low mood and apathy, because there is underlying attention deficit trait in them, stimulants would be a good long-term measure, and stimulants are autonomic nervous system stimulation producer rather than they are blockers. So depending on specific background process, we have to introduce specific medications later, and that would at times contradict the initial medications. Then, if the initial combination doesn't work, we have to change the medicine according to the non-functional area. If euphoria didn't happen, change the euphoria-inducing method. Means, let's say RTMS has failed or deep TMS has failed, then ECT is a good option. If ketamine doesn't work, LSD, ecstasy would be a good option. If long-term symptom relief medication, antidepressants doesn't work fully, adding another appropriate medication or replacing it would be better. For example, I have started patient with escitalopram because I felt that initial presentation has equal anxiety symptom as well as apathy and restlessness. So I had started on escitalopram. But after full dose of escitalopram, which might be 30 or 40 milligram depending on the patient's tolerance level and the symptomatic response, if I see that patient still complaining of anhedonia, amotivation, apathy, but patient has improved on restlessness, then that means I need to add another appropriate medication because escitalopram won't be able to make the patient feel fully better. There, I can use one medication that would be more of a pick me up kind of medication or which has activating property. Let's say bupropion, let's say fluoxetine, let's say desvelna vaccine, and that would cause a good combination for the patient. Or if even after 30 milligram or 40 milligram of escitalopram, the patient has not responded to either restlessness, anxiety, or the apathy and low mood, then it is better to switch to another depression, another antidepressant, which might be paroxetine, which might be other, depending on our understanding of the symptomatology. In some people, there is initial response followed by relapse. That signals that real pathology is getting into way of treatment and more energy and effort needed to direct the treatment there, be it background attention deficit trait or background obsessive trait. If there is background attention deficit trait and that is causing the relapse, then we need to start treatment for that with stimulants. If the background obsessive trait is there, then we need to start adding memantine or drugs like memantine, which would modulate the obsessive trait. Now, anxiety. Anxiety is actually the complementary part of apathy and low mood. Here, brain is hyperactive in an ineffectual and inefficient manner. It is the complementary part of low mood in vicious cycle of brain failure. Brain cannot function properly, tries to be hyperactive, fails more functional restriction. When brain cannot function properly, there comes low mood. When tries to be hyperactive, there comes the anxiety part. When it fails more, anxiety gives way to low mood and more functional restriction. And so anxiety and low mood always comes hand in hand. So anxiety never comes alone. Treatment is the same formula. Immediate relief agent, long-term agent, and autonomic nervous system modulation and SOS agent. If this symptom is more in symptom combination of low mood and anxiety, then fast relief agent becomes benzodiazepine and rest would be the same. Now comes delusion and hallucination. Sorry, I'm not saying psychosis because psychosis is again a very complicated way of saying that I am clubbing things together. So it's better to think as delusion and hallucination. This is the flowchart of delusion formation. This is delusion is combination of three processes: increased autobiographical process, high extended motivation or reward circuitry tone, decreased inhibitory control, and decreased executive function. These three leads to fixed firm belief, not amenable to radical reasoning, also known as delusion. And each of these processes individually would lead to various other symptoms. Increased autobiographical process would lead to obsession and rumination. High motivational tone would lead to compulsive impulsive behavior. Decreased inhibitory tone and decreased executive function would lead to attention deficit trait, addiction to process and substances. So delusion stands at the crossroads between three processes which are pathological in excess themselves. So delusion doesn't come alone. With delusion, there would be many a time rumination, many a time there would be compulsive impulsive behavior, many a time there would be attention deficit and addiction to process and substances. And based on them, the treatment changes. And hallucination is result of delusion. First, all delusion pharmacy machinery should be active. Then there should be disturbed sensory discrimination network, disturbed sensory integration network, which together would produce disturbed spatial perception and orientation and would lead to hallucination of all sensory modalities. This, although auditory is the primary disturbance mostly. So in case of delusion hallucination, the first drug needs to be something that reduces brain excitability and activity. Antipsychotics fit the description. They reduces excitability, brain activity, and brain transmission. And so any of the antipsychotic doesn't matter, would be a fast drug. The second drug needs to be something that slowly increases brain efficiency and brain function. Antidepressants fit into that requirement. The third drug needs to be autonomic system modulator. The fourth drug needs to be acute anti-excitability medication, because until and unless we stop the breakthrough acute excitabilities, patient would not stick to us. So benzodiazepine, lemborexant, or centrally acting relaxants would be a good drug for this acute anti-excitability medication. And then along with this, for delusion, we need to address to this process, increased autobiographical process, which fortunately is amenable to antidepressant. High or extended motivational or reward circuits would be something that is amenable to antipsychotics as well as various other drugs. Decreased inhibitory control is again amenable to antidepressant as well as naltrexone and other drugs. So they would come as and when needed drug. Now, the long-term process. If the initial measures doesn't work in hallucination and delusion, there needs to be another drugs needs to be added, which would reduce excitability of brain. Both anti-epileptic and antipsychotics are going to fit here. So if one antipsychotic is not working fully, we have the liberty to add another antipsychotic. For example, I have started with olanzapine. I am finding that it is not working. Then I have the liberty to add haloperidol or risperidol or any other dose. Then I can also not use another antipsychotic and I can use valproate with it. I can use other antiepileptic with it. Then comes the adding drugs to stop further progression, because hallucination and delusion means brain has tipped to a certain point where there would be further progression until and unless we use something. Lithium, antidepressant, memantine, various other drugs. A lot of drugs fits in the neuroprogression segment. They can stop the ongoing neuroprogression. Then the next step would be lowering drugs that suppress brain excitement. Once the brain excitability is over and the patient is coming out of that extreme excitability of hallucination and delusion, we have to stop the antipsychotic, or rather we have to reduce the antipsychotic, we have to reduce the anti-epileptic, so that the cognition, that is the cognition loss, that is going to be a part and parcel of this whole process, doesn't get much more. And we need to increase the drugs which increase cognition here. So I hope by this example, I have given you some idea on how rational polypharmacy can progress. We can do this exercise for each symptoms, but that would make it tedious and you would get bored. So here I would start to sum up. And to sum up, I first have to say that monotherapy is outdated concept in every non-communicable disease. But polypharmacy, which is going to replace monotherapy, needs to be judicious and needs to be rational. Multiple complementary approaches should be combined in a single symptom treatment. Target of individual symptoms to be done in a short-term and long-term goal. And always remember, psychiatry is 18th or 19th century medicine, which we practice in 21st century. So we have to understand that at 18th or 19th century, medicine didn't have any opinion leaders. Medicine didn't have any evidence-based practice. Medicine didn't have consensually agreed upon statement by a group of enlightened individuals who are considered expert without any proof of their expertise. So if we are going to practice that medicine in 21st century, then we have to be as open-minded as is possible. We need to follow scientific rationally and symptom-based management, and rather than we have to stop using imaginary evidence-based management, because psychiatry neither have any evidence, nor have any data, and all we have is just mutual agreement based, some expert opinion, where the expertise of the experts are determined by themselves. That is the unfortunate story of psychiatry. I am ending my presentation here. I hope you have questions and have some opinions.
Thank you so much, Bhaskar. I think it was one of your finest presentations that I have heard. Very, very smooth and to the point and driving home the point. And I think many things that were in our mind confusion have been cleared. So a very well done presentation. Over to chairpersons for their opening remarks, if any.
Dr. Amrit, please unmute. अच्छा, ask to unmute. आपको बनाया नहीं क्या host? हाँ.
Many of the things which Alim did not know, he got to know today. That was good.
Salim is always learning.
Hanji,
Okay,
Dr. Vinay,
okay.
the opening
Yes,
comments.
yes. Thank
Dr.
you.
Vinay.
Thank you so much, Bhaskar. So, you really challenge our thinking, our traditional thinking, and it's always useful to have a different perspective. And I hope that the way you went about explaining different things made sense. I also hope that you can share some of your references on the basis of which you've talked about your work. So I think I leave that to the moderators to share that information later on. We've
Yes.
got a few questions coming up already, and Rajesh, I think you are very happy to take over if you want.
I think Rajesh is still busy. I think
Busy.
he's
Okay.
taking
So
that assessment, special assessment.
I
Yes.
will start with the first question, where the first question really was about, can we switch antidepressants and antipsychotics without gradual titration if they belong to same class?
There is no second, there is no class. SSRIs doesn't cause anything in serotonin. SNRI doesn't cause anything in serotonin and norepinephrine. There is no class. So the first we have to understand there is no class. So no medicine is simply replaceable by another medicine. We should always do a cross titration that is comfortable for patient, that is better for the patient's overall experience, and that is better for us to understand if the things are working on. Direct switch has many problems, so it is always better to cross titration.
Okay, thank you. And there is a comment there about a lot of patients who do well on low doses of benzodiazepines for they've been on them for a long period of time. So what are your thoughts about patients who are on low doses of benzodiazepines and taking them for a long period of time?
There are many patients like that. Now, benzodiazepines, we have to understand, are a group of medicines which are anti-epileptic, which are drugs which causes suppression of brain excitability and brain function, and they are also medication which causes drowsiness. So standing there, if a patient is on low dose benzodiazepine for a long time, they are having some inherent hyperexcitability of brain, and so by suppressing that hyperexcitability, the patient is feeling well. Whether we need to stop the benzodiazepine or not, that depends on whether we are seeing the patient increasing their dose of benzodiazepine by themselves or not. If a patient is stable on, let's say, 0.5 mg clonazepam for a long time, and patient is not increasing the clonazepam, patient is not doing anything with the medication and still working fine, we should not meddle in the affair between patient and the clonazepam, because then we run a risk of destabilizing the patient's brain. But if there is chronic increase, use of benzodiazepine, there is evidence of addiction getting developed, then we should interfere, we should step in, and we should do a switch to other medication, and we should start that treatment proper.
There's an added question to it, Bhaskar. Zain has asked, should atazolizumab be combined with clonazepam for refractory anxiety? Like, can you, like we combine two antidepressants, two anything? Can we do that?
If there is no refractory anxiety, if we are having refractory anxiety and we need to combine two anti-epileptics for it, I am not using benzodiazepine name. I am using anti-epileptic because they are anti-epileptics. So if we need to combine two anti-epileptics for controlling hyperexcitability, then we are missing something. We are there is no inhibition in combining these two drugs, but I would suggest look for something that we missed in the history, look for something that we missed in the treatment, because that would be a very rare event where two antiepileptics are needed to control anxiety, which is a moderate, mild to moderate level of hyperexcitation.
So, Bhaskar, there are a few other questions. Obviously, there are
Hmm.
some questions around the evidence. So, I think
Hmm.
it'll be useful to share some of that.
Yes,
But then,
there are
then the
actually, if anyone is interested, they can do a search on polypharmacy. Not if they don't even have to do on psychiatry, they just have to search for polypharmacy. They would
okay,
get about 100 reference.
okay.
But
So, but a short collection of references would be useful.
Yes,
So
yeah,
that is one.
you can.
Yeah. And then, so the other couple of questions which are there, they are about obviously pharmacotherapy is lifelong for a lot of patients. You've talked about four different types of medications for to address all of those different areas, and then there is an element of uh, burden from multiple medications in terms of side effects. So how do you balance that aspect of it?
Pardon.
So how do you balance an aspect of the fact that patients will be on multiple medications in order to
patients
provide?
patients need to be on multiple medication, and if we follow the judicious treatment, then we would find that each medication would cancel various adverse effect of other. For example, if we combine sympathetic blocker with antipsychotic, we would be limiting the metabolic effect. We would be limiting the mild EPS that we many a time overlook. We would be limiting a lot of other effects of antipsychotic. Then, if we combine, let's say, antidepressant with benzodiazepine in the initial period, then benzodiazepine would mitigate some of the symptoms of antidepressant that may cause discomfort in patient. If we combine anti sympathetic blockers with antidepressant, then again initial anxiety would be covered. So if we combine medication working in different areas together they would actually nullify one another's adverse reaction. I would not say adverse reaction, I would say off target actions.
Okay. And then there are a couple of other things. So there is something here about role of clozapine. So whether if people do not respond, with delusions and hallucinations, then where does the role of clozapine fit in all of this, along with memantine and autonomic nervous system modulators and things like that?
We have to understand that that clozapine and cane trial came in 1988 when I was 8-year-old. Today I am 46 years old. So we have to understand that the cane trial needs to be challenged and replicated again. In psychiatry, we make axiom of everything. We do not try to replicate things. We do not try to cross-examine any of the previous trials. It is time we start doing that. We need, that is why so much replication crisis is plaguing our discipline, because this plague is happening because we don't try to refute and revalidate our old beliefs. Clozapine is not the best drug that it is touted to be, because there is no evidence after 1988 that it is indeed superior to everything. This is just a collectively held belief with not much scientific validity to it. Number one. Number two is clozapine is unique because of its very low ability to cause extrapyramidal effect, its very low ability to worsen hyperkinetic movement, its very low ability to induce various medicine emergent side effects. So clozapine should be given its due respect for these effects, not due to the fact that once someone has done a paper which says it is working in refractory syndrome. From compared to 1988, we have a plethora of new drugs today, and clozapine needs to be retested and recalibrated based on its efficacy and effect on these new agents.
Just to add on to that, Bhaskar, since you say there are no psychiatric disorders as such, right?
No,
We just treating symptoms. So what about, the question is there by Dr. Hema also, what about treatment resistance? Is there really
treatment resistance is
treatment refractory? Is there something like that actually or no? According to you?
After working 20 years in treatment resistance, I would directly say treatment resistance is a handed down word by psychoanalytical people. In psychoanalysis, there is therapy resistant patient, and that idea has been handed down to modern psychiatry when we started this so-called modern psychiatry. In psychiatry, treatment resistance doesn't happen. What happens is some symptoms are refractory to begin with, number one. Number two, there is inadequate treatment to inadequate number of patients due up to inadequate dose to for inadequate duration. If we correct this inadequacy, there would not be any treatment resistance in psychiatry.
Okay, Bhaskar. So as usual, challenging existing thinking. So one of the thing which somebody's put up there, which is quite appropriate, is a lot of our patients, they are reluctant to take multiple medications, because polypharmacy is not just what the prescriber prescribes. It's also about the patients taking it, and there is of course some evidence, and people could refute it, but it impacts drug adherence and compliance, or adherence or compliance, whatever you call it. And then of course there is a cost element to it as well. So how do you suggest how we kind of approach and manage it? I know that you can, talk to your patients and give information to them, but do you have any thoughts around patients' perspective about them being on multiple medications?
If we start with combination polytherapy, then the patient would not worsen rapidly. Patient would have a better cognitive function, and as time progresses, we would be able to reduce the number of drugs to one or two. This is actually the step down procedure. In step down procedure, I have given example without naming it. Step down procedure is a standard practice in medicine where we start with multiple medication at first to make that dysfunction respond faster, respond better. But after some time, when patient starts stabilizing, we start withdrawing various molecules to keep the patient stable in one or two medication. Step down procedure was once very appealing and was very strong in COPD and asthma only. But now in all other non-communicable disease, they are also following this same step down format. Start with multiple complementary medicines first, so that patient doesn't worsen at the initial period. And once patient's disease process stabilizes, start withdrawing medication to keep them on one or two medication. That is how step down procedure works. Rather than previous use step up procedure, when we start with one medication, patient worsens, add another medication, patient worsens, another medication, and ultimately, in the long run, patient get more medication and exposed to more financial risk.
Okay. So it's a bit of a process of working with the patient and explaining to them what you are doing and why you are doing it so that it can help them understand the rationale
Yes.
behind it.
Yes, and in the long run,
So-
step down procedure involves less drug exposure, and less drug burden than step up procedure.
So you
Bhaskar,
also
you're saying
mentioned,
you are altering the natural course and progression of the illness by way of
Yes,
psychotropics.
yes, the nature. If in every other non-communicable disease segment, the current thought is now in the early phase, keep them in such a way that the worsening doesn't happen.
okay, okay. Now you've also talked about, you know, delusions and hallucinations and the role of lithium and memantine. So talk a bit about where their role, lithium's role is in people who are presenting with those kind of symptoms.
In these patients who have delusion or hallucination or who have psychotic mania or things like that, in them, the primary problem is acute severe hyperexcitability of brain. That is the main dysfunction in them, and their brain is prone to such rapid hyperexcitability from time to time. Now, if this rapid hyperexcitability, paroxysmal hyperexcitability occurs in brain of this patient, there is every chance that with each violent outburst, there would be cell death and there would be reduction in available number of neurons and neuronal stem cells. So there is less chance of recovery. And the more these episodes occur, there is step down worsening of these patients, and ultimately they would go into neurodegeneration. Lithium, which is a immune system activator at low dose, actually causes reduction of this excitotoxicity process. Similarly, memantine and in rare cases amantadine also causes reduction of this excitotoxicity by reducing the NMDA receptor overactivation and various other molecules. For example, some newly found anti-diabetic agents. For example, the GLP-1 agonist, GLP-1 GIP agonist. These new groups of drugs, they also have the same properties. So these drugs would be able to reduce the sudden severe excitotoxicity and ultimately would make the brain survive longer. That is where they come.
I think the questions are starting to dry up, but we will ask go through a few more things.
I have a question before.
Yes.
Yes, Vishal.
I was thinking about one of the biggest challenges in psychiatry is to deal with negative symptoms or so-called negative symptoms of schizophrenia. You know?
Yeah.
So we do very well still with hallucinations and delusions. The patient's better, not agitated, and no aggression. But then patient is just sitting in his house, not doing anything. What do you do with that? What are your thoughts on
Negative
that?
symptom is nothing but antipsychotic burden making the cognition dry up, and along with that, whenever there is severe excitotoxicity, the follow-up is reduction of brain activity. So in negative symptom, start giving antidepressant. Start giving antidepressant in proper dose. Start giving brain cognition enhancer, or what we can call as
Modafinil?
modafinil and other group, which is known as activated drug or so-called ADHD drug. Each of them have their own efficacy. Modafinil is the mildest, then comes bupropion, then comes atomoxetine, And even in severely withdrawn retarded cases who have stopped even speaking, there is methylphenidate. Start low, go slow, that cause improvement.
Yeah.
Negative symptom is negative because we are thinking in terms of positive symptom only, controlling that. If we start understanding that deficit state arising from lack of brain excitation, lack of brain's usual function, then new avenues open up. We start using antidepressant, we start using attention enhancing molecule, we start using medications which have a pro-cognitive effect and things like that.
Okay, so just last few questions and then we will wrap it up. So your approach to managing OCD. Somebody's talked about a combination of antipsychotic and two anti-OCD drugs and in severe OCD. So what's your approach to managing OCD?
First, obsessive OCD doesn't exist. What is there is a long-term obsessive compulsive personality trait which started at birth and which gradually matured to a very finicky, very obstinate, very detail-oriented person who then develop a destabilization of this process and landed up in compulsive behavior more or obsessive rumination more and things like that. So standing on that, depending on what is more, we have to start treating that. Let's say obsession is more. Obsession is more means brain's functionality has to be increased and there has to be some agent which would stop the hyperactivity, hypervigilance and getting triggered. Antipsychotics in low dose stop the amygdala hyperactivation and amygdala to thalamus projection hyperactivation, which leads to this hypervigilance. So antipsychotic in low dose would stop the trigger. Then with obsession, we need to increase the brain's function. There comes role of antidepressant, and any antidepressant is useful. We have to stop on our this obsession with only fluvoxamine, only clomipramine. If we start challenging our preconceived notion and we start using all the antidepressants that we call as antidepressant, then we would find out venlafaxine is as good as clomipramine. Venlafaxine is as good as fluvoxamine in controlling obsessive thoughts. Then come the compulsivity. Compulsivity is a different beast altogether. Compulsivity means the brain has entered in a re-entrant circuitry in case of motivational circuit. So for that, we need to use drugs which reduce the compulsive behavior. One target is naltrexone, another one is memantine, another one is various medical cannabinoid which modulate the motivational circuit or the reward circuit in layman term. And that way, by combining these different approaches, we can treat OCD. But remember, there is no OCD. This is just worsening of a pre-existing brain vulnerability pattern that started at birth and that would end up in either Parkinsonism or Alzheimer type of neurodegeneration, or that would end up in various other systematic illness. Those who develop diabetes, if we follow them long term, they have more preponderance of obsessive compulsive personality. Those who develop severe level of hypertension or severe level of other non-communicable disease, they also have more prevalence of anantastic personality or obsessive compulsive personality. If we search obsessive compulsive personality and diabetes, we would find the evidence. If we search in Google Scholar obsessive compulsive personality and hypertension, we would find the evidence. I am not saying that believe me. I am saying challenge me. Search these keywords.
So
Yes,
I'll
that's good.
challenge you now. I'll challenge you now, Bhaskar.
Yes, Amrit.
So you talked about OCPD, starting as OCPD. But if you look at, and I think I have a fair enough good practice where a lot of OCD patients come, but the comorbidity of OCPD and OCD is very, very low.
There is no comorbidity.
Let me tell. I know you're not talking about comorbidity. Let me complete. So you are telling it starts as OCPD. Now you're talking about OCPD, which you are speculating.
OCPD, no. OCPT, obsessive compulsive personality trait. When you say
Okay, anyway,
obsessive
traits.
compulsive personality.
Okay, traits. I got your point. It's not PD, it's traits. But whenever we get a OCD, we also backtrack whether somebody has a component of OCPD trait or OCPD per se. And to be honest, it's a very, very rare, combination. Let me. No, you don't tell no. You are no God that you whatever you tell, I have to accept it. Let me be very honest. Well, if you say patience, I also see patience. No, listen to me. I am listening to you. You'll have to listen to me now also.
Okay.
So how do we? You are speculating that they have this thing, and I am telling that they don't have. So there is nothing. It's your theory or 5% theory. Let me complete. I did not interrupt you, Bhaskar.
भास्कर भाई उसको बोलने दो, उसको बोलने दो.
आप बोलने नहीं दोगे, आप बोलोगे फिर challenge. Then. So I have found that this component is very, very low. Now if you look at diabetes, again diabetes is very, very common now. आप किसी के साथ correlate कर सकते हो diabetes को. I can tell that somebody is wearing specs, he has diabetes. That's also a big correlation now. Because of lifestyle changes, if you look at diabetes, what was happening before, now if you look at hypertension, if you look at coronary artery disease, the correlations will be very, very high. So you are not speaking something which can be just a correlation. It can be a coincidence, and it's now a very, very common coincidence now. So I will take whatever telling with a pinch of salt. Okay, your treatment part is different, but the whole etiology, how it develops, I will not accept it as a OCD trait or OCP traits going into a OCD. And that's where the very fundamental of many of the things will differ. The whole ego syntonic, you give a trash to whatever it is, but the ego syntonic part and the ego dystonic part are important parts of differentiation.
The thing is, ego syntonic, ego dystonic doesn't matter, because again, the question of this ego doesn't come. What is syntonic and what is dystonic? A person who has been comfortable with various ritualistic behavior may not be comfortable when the ritualistic behavior and thoughts include some God in that ritualistic behavior. So in other part of life, the person is pretty okay with excessive cleanliness. The person is pretty okay with praying to God for 2 hours. But that person would get very, very disturbed if someday the person starts thinking about the God and there comes swear words in the person's brain. So there, initially, the person was very, very happy with the ritualistic behavior.
No, I object. Again, I will object and I challenge you. Because I have talked to a lot of hyper-religious people. And many of them I found religious OCD is very common. If you go back, you've never talked to normal people. When you talk to hyper-religious people who have not come to you, and you just go and ask them. Take them aside and ask them. People who have not come to a clinic. I have found a lot of religious OCDs in them.
Yes, they have religious OCD.
So they were not comfortable. They were able to hide it properly. It is not the comfort level. Because until you don't ask about religious and sexual OCD, people do not come out.
Again, the thing is, you have to understand that they are ritualistic in their behavior. But in some areas, they are not comfortable with the rituals. In some areas, they are comfortable. So ego syntonic, ego dystonic doesn't matter. I am actually habitually doing, let's say, I myself have a tick of grunting when I eat. That is a tick I am comfortable to live with. But if suddenly I start developing other ticks, I would be very, very distressed. And so it would be actually not given to attention that I have other comfortable things that I am doing.
Okay, Bhaskar, I think
the degree of distress. Last line. I will not speak after this. It is the degree of distress. It is not the distress. Again, I'll tell you, it's the degree of distress. With a tick, I will have a small amount of distress. When I do have this vocal tics, when I'm, speaking out expletives, I will have much more distress. So depending on the degree of distress, I will come to the doctor. I will not come to the doctor. That also depends in a lot of time. Thank you. I will not speak more.
That's fine. Okay, now Bhaskar, couple of questions and then we'll wrap it up. There's a question there about that there are lots of anti-epileptic medications, but many of them are not useful for people with psychiatric presentations.
Like,
I don't know. Somebody said, we use only some anti-epileptic medications rather than several of them, which neurologists use to treat epilepsy.
It's like we have many more anti-epileptics, but in psychiatry we use only 3-4, right?
Only 3-4 of them.
That is the user's perspective. That is not the scientific perspective. If someone is comfortable in using oxcarbazepine and someone is saying that only oxcarbazepine is good for psychiatry, then that is just a personal bias. Every antiepileptic can be used in psychiatry as they are used in epilepsy. So if you want, you can, I am again saying, go to evidence base and check. Eslicarbazepine, which most psychiatric doesn't even know about, eslicarbazepine and use in impulsivity or use in compulsivity, and you would find out evidences. There are evidences.
So I think a couple of people have asked questions about getting references from you. So we will get that references from Bhaskar. There's a question there about, so people get better and then there are questions from the patients and families. Can we stop the medications?
No.
So what's your thought about those who get better? How long do you continue or stop the medication?
Until and unless it is a spontaneous low mood episode due to grief, there is no escaping from non-communicable diseases of brain. It is not possible. They are there since birth and they would exist till date. The form would change. Someday a patient would come with low mood. Next day the same patient might come with panic attack. A few months later, the same patient might come with paranoia. Few decades later, the same patient would come with executive dysfunction and symptoms of might be frontotemporal dementia, but they would come.
Okay, so then brings a question I have is, that's just my question, okay? So why is it that we are not advancing science the way you propose some of your theories? Why is it that everybody else, of course, there's a lot of work happening across the world. Why are we not advancing the science and doing studies, trials, whatever, in the way you talk about some of these things? And why are you not doing some of that work?
For that, I need to have a dedicated lab, which I don't have.
Well, I need to have other people not doing it.
Why are the other people not doing it? Because in all branches of science, people love to follow the convention. People love to follow the rut. If you question the rut, if you follow the convention, nobody would like you. And people are afraid to be unpopular.
So I think...
and I am not the only one who are asking this question. Some of them are going into wrong direction. So they have stamped themselves as critical psychiatrists, but they are also asking the same question. But they are trying to find answer in philosophy. They are trying to find answer in esoteric areas. I am trying to find answer in biology. I am trying to find answer in brain sciences. But the questions I actually ask and the questions I answer from this perspective, the same things critical psychiatrists also ask. Be it Be it
Alim?
Joanna Moncrief, be it Anne Harrington, be it any critical psychiatrist, they all have asked the same question. I am answering from biomedical perspective. They have gone to history, they have gone to sociology and other
Thank
things.
you.
Okay.
Thank you, Bhaskar.
Alim?
Lakshman sir, want to ask one question,
Yes,
which
yes.
is a combination of many questions. So, Bhaskar, just to come back to the topic at hand, you said polypharmacy. We can say various dimensions. So you said that initial impact, what is the acute effect we want, then we want a long-term stabilization, then we want an ANS stabilizer, and then we want disease modification process. So what are those things? What is the initial measures that we take? And what are the options that we miss out? We usually use benzodiazepines initially so that the anxiety is there. So suppose what are the other things that we should take care of in our
We
practice?
don't use autonomic nervous system blockers enough. It is unfortunate that in
Which are
20
name them
propranolol, clonidine, prazosin.
in
I
doses.
had
What doses?
in doses, adequate doses. Propranolol should be 1 mg per kg for most of the patients. Clonidine should be gradually up titrated, but in many patients, it is required up to 300 microgram or more. Prazosin should be started at 2.5 mg at night, but the dose should increase up to 10 mg. None of the people were using these before before they were subjected to a lot of verbal debates and various other motivational techniques.
Okay. So this is one part. ANS medications that you say are underutilized and should be utilized more. So you said that drugs directed.
There is also a huge group of drugs which are not used. This is drugs that modify long-term use disease trajectory.
Please name
Antidepressant.
them. Please name.
Antidepressant cause that. Number one. Number two is memantine, or for example, lemborexant or doras. They have long-term disease modifying effect. We don't use them. Lithium too also falls in same category. Then comes another group of drugs that we don't use enough, that is stimulants. We have created a block in our brain where we think that they are for attention deficit. They are not. They are for enhancing the brain's ability to give sustained attention to anything. That can come as many symptom combination. Even some obsession even in some obsessive compulsive symptoms, giving stimulant works better and make the so-called resistant patient suddenly amenable to treatment.
Alim, last question and then we wrap it up.
Memantine where all?
Memantine would be given there where there is repetitive thoughts and repetitive action. Yes, we also never have given naltrexone to a lot of patients where we have again stamped these as addiction drug. Naltrexone can be given for suicidal ideation. Naltrexone can be given for every impulsive compulsive behavior. Naltrexone, nalmefene, both can be given for a lot of compulsive acts.
Okay. So
how effective are they?
They are very effective. They are very, very effective.
Okay, Alim, I think we are towards the end of it. So thank you, Bhaskar. I think I'll just summarize before I'll hand over to moderators. So thank you for sharing your thoughts. We certainly, of course, are very different to a lot of traditional thinking and what many of us think about. It's always useful to think differently. It's always useful to challenge, but with some evidence. And so I think what we've heard is a slightly different approach to addressing psychiatric issues. It'll be good to have some of your references, and if you are engaged in some of that research, because at the end of the day, having that evidence behind whatever claims we make is very, very important. Otherwise it makes it difficult not only for professions but also for our patients and their family members. At the end of the day, I think we all want our patients to get better, and I think if we can use rational polypharmacy to get our patients better, that's a useful thing. I hope that many of the colleagues they got something out of it. They might have agreed or disagreed with some of the things you've talked about today. I would encourage them to do their proper research and search, not just Google search. Google doesn't know everything.
Google search by Google search, I meant Google Scholar search.
Google
never
Scholar.
never do a normal Google search.
But do some proper search and use your expertise and experience over the years to decide on your thinking. I want to again thank Bhaskar for taking the opportunity to talk about some of the things, knowing that some of these thoughts are not necessarily agreed upon by other people. That's a challenging thing to do. And I also want to thank Vishal, Aleem, Amrit, and Dr. Tufan for giving me and Rajesh an opportunity to chair and be part of this interesting session. Over to you, guys, Aleem, Vishal, and Amrit. Thank you so much.
Thank you, sir. Thank you, sir, for your kind words. So I think the questions are over, and since Lakas has ended the session, so we continue this on the live CME group. I think, Bhaskar, you will be available there. And many people are asking for references, so we need some references.
I have told them. Just
you also post it on the live CME.
People want it from your side. Please put it,
So post a few good references on the live CME, so we'll distribute.
We want the chicken that lays the golden eggs. So
yes. Yes.
Amrit, over to you. Tufan sir, over to you.
Thank you very much. It was a nice evening, and there is a lot of information overload. But times when there is information overload, it leads to confusion. At least those who consider it overload, that is how there has been a little difficult on some of our participants to accept all that was told by Bhaskar. Dr. Bhaskar?
Yes.
Your points well taken, but I think the consensus is that they need a little more evidence, and, instead of sorting themselves about the delicate aspects, if you can provide in this group or in live CME group, it will be better and more convincing. And thank you very much. There are many things we do, we need a rationale for this, and there are many things he suggests to do for which we also need a rationale. And all these things that we have been told today is there to enter into standard practice guidelines. So which will be really great support if Bhaskar helps in evolving that. Thank you very much, Bhaskar.
Thank you. Amrit, over to you.
First of all, let me congratulate Bhaskar. He always doesn't let you sleep. He'll challenge your way of thinking. But if you look at the end of the day, what Bhaskar is doing and what we are doing are almost similar. But the only thing, he has a rational, he has a logic. We are doing more of hit and trial and using our experience to treat our patients. And Bhaskar gives you a logic why he's doing it. He challenges you to think why you're doing certain things. And most of the things we are doing subconsciously. We've learned something and that's what it is. But what the intricacies, how the things are changing, I think that's what Bhaskar teaches us. He also does a lot of things what we are doing, and we do a lot of things what Bhaskar is doing. So if people get overawed by what Bhaskar is doing, I don't think he's doing something which is out of the moon. He's doing most of the things what we are doing, and that's what I am telling. Some of the fine tuning, I think that's what we learn from Bhaskar. grossly we are doing the same thing, but when you are in a fix, when you are, he's also my go-to man. I call him a Bhaskar, kya kiya jaye? And he tells you do this, do that. He tells you something different. And many of the times we think that we have tried out everything and there is nothing left. So we call it treatment resistance. Sometimes I call it a symptom resistance, maybe because of the resistance in our mind. So that's a resistance which we have. That patient is not going to, we brand them so soon, so far. So it was very stimulating, Bhaskar. References and all, whether you give it or not, we think you are the reference for us. And we accept most of the things. We accept most of the things because we know that you are doing the hard work for us. You read all the things, you simplify it us and give it to us. And we know that everybody has a bias. So we are happy with your biases also because that makes us think differently. Thank you, Vishal. Thank you, Tufan sir. Thank you, Lakra boss, for conducting. It's 3 o'clock in the morning for you. I know it's tough, but you're still smiling. You are still relaxed, and we were able to do it like you used to do your rounds in Maudsley Ward.
I'm in Delhi.
So it was great. Thank you for the great audience. We had a lot of people lapping up what Bhaskar is speaking. And chip ke sab ab acha practitioner banenge. So thank you again. Good night. See you again next Thursday, another episode of Thursday Music.
Thank you.
Thank you.
All of you.
Bye-bye.
Thank you.
Bye.
Thank you so much.
Thank
Good
you.
night.
Thank you, Bhaskar.
Thank you.
Good night.
Thank you.
Good night.
Dr.
Thank you.
Fan,
Good
Lean.
night.
Good night.
Bye. Good night. Good night. Ending the session.